I usually prefer to do retinal grafts instead of amniotic membrane. So this one, this is like a illuminated infusion line from BNL that it's allow us to do a bimanual surgery without having to add an extra choker, so an extra sclerotomy. So it's really nice.
Tell us a little bit about this one.
Yeah, so it's called a high flow illuminated infusion line. So you have a little chandelier in the middle of the infusion line, and so you actually it's a little bit different than the Alcon choker. This one will actually fit over the infusion line, will fit over the choker. So it's a different choker than the choker that we usually do for the standard vitrectomy.
Where's the fiber?
So it's inside the infusion line.
Okay.
Yeah. So you have you plugged. You need an adapter to connect to the Constellation. I operated with the Constellation. You have an adapter to put the fiber optic of the Synergetics Instruments, which is now BNL. So this is what it is.
You can actually use this whether you're using a BNL machine or an Alcon machine.
I use the Alcon machine, Constellation. Yeah, you can use it. You can use it
nice.
either.
Yeah, it's nice that you can hook it up. I would probably use more. I'd probably use more chandeliers if I didn't have to make an extra hole and put in a chandelier. Just have it as your infusion.
Exactly.
I like that.
Yeah, it's elegant actually. Go ahead. Yeah. And then it's actually the way it's made. I don't know if it's because of the infusion line. It's easier to fixate than some of the chandeliers that have like a harder cable attached to it. So it's easier to have it pointing towards the area that you actually working towards. So yeah. And if you don't have the infusion too high, because my concern was to have the infusion too high, and you're actually jet streaming fluid towards where you're working. But if you don't have it too high, this doesn't happen. So,
sure.
And so now I tinted the non-sticking surface of the ILM with Vision Blue, just in case it slips out of my forceps. I know which surface is which. So the unstained surface would be the sticky surface, which is the one that has to be towards the retina. I switched. I used to use a smaller amniotic membrane graft, but now I'm using a larger graft. And because it's not very easy to stick to the retina surface, so I like to have like a nice edge way beyond the macular hole to have more surface contact to allow it for sticking. Go ahead. But when you have a bigger graft, you have to open an additional port to make sure that this doesn't get stuck in the choker. So I did a trans conjunctival 20 gauge sclerotomy just to place the amniotic membrane over the retina, and then if you do this, then you have a constant flow, and then the amniotic membrane can totally fly away. So as soon as you place the amniotic membrane on the retinal surface, you see that it doesn't stick, right? So then I use like a bimanual technique. One hand I keep it in place, and the other hand I put the PFC, and this will hold the ILM in place, the amniotic membrane in place. And then as when the amniotic membrane is in place, then I go ahead and I suture the sclerotomy before I go ahead and continue to play with the amniotic membrane. And I like, so you don't have to do intraoperative CT. If you have, it's nice to confirm that it's properly placed. And I just did a retinotomy because my hole was already, I didn't want to do all this technique under air, so I wanted to drain the subretinal fluid. I usually don't do posterior retinotomies, but in this particular case, my ILM was already in place in the hole, and I did a retinotomy, which I regret tremendously, but that's how I drained the subretinal fluid in this patient. And at the end, because it was a sizable hole, we put a little bit of tissue over the amniotic membrane graft to make sure that it stayed in place, and we put gas.